Good morning. It's a thrill to be back. I wasn't booed off the stage the first 2 times. We'll see if I can do it now. So I'm going to talk about pediatric thyroid cancer, and as you all are aware, a new set of guidelines has come out, and it's very exciting that we are acknowledging that children are in fact different than adults. And there are some important points that are different than an adult guidelines, so I'm trying to highlight that, and we're going to do it in a case-based format. Again, you've seen my disclosures. I work for Genzyme as a consultant, a speaker, and an advisory board capacity. That will not affect my talk today. So we're going to talk first about thyroid nodules. We'll then discuss the extent of surgery and radioiodine therapy. When is it indicated? When is it not? And then we'll talk a little bit about surveillance after therapy with either surgery or radioiodine or both. So first case, this is a 13-year-old. I actually am an adult endocrinologist, but I do see pediatrics in my practice. Until about a year ago, we did not have a pediatric endocrinologist in our town who focused on thyroid disorders, but we've now changed that. So this is somebody I picked up a couple of years ago. So she's a 13-year-old, and she presented with a mass in her lower neck. It was noted on a routine physical exam by her pediatrician. It was not painful when you touched it. It was not enlarging. The family hadn't really even noticed it. There was no prior history of radiation. She has no family history of thyroid cancer, but her mother does have a history of hypothyroidism. Her exam doesn't show anything remarkable other than the neck exam. There's some fullness on the right that is a little more full than the left, but overall her thyroid is enlarged, but the right lobe is a little bigger than the left. There's no lymphadenopathy, and her serum TSH is mildly elevated, but within the normal range. So this is the ultrasound, and for those of you who aren't familiar with ultrasonography, I'll just walk you through this. This is anterior, this is posterior, this is right and left, this is the trachea, the carotid, and then this big mass here, the hypoechoic mass, is her thyroid. And it is a hypoechoic gland, and I can say that because it's as dark as the surrounding strap muscles, which are located here. And if you look at it in the sagittal view, the gland is between my cursor here. And you can see that in the right lobe, there are microcalcifications throughout that gland that are pretty readily visible, but there's no distinct mass. And then in the left, you see the gland is a little bit smaller, and it's heterogeneous, so you see some little small areas of hypoechogenicity. This is classic for Hashimoto's thyroiditis. But she's got this asymmetric presentation of the gland where one lobe is larger and there are these microcalcifications, which is very concerning. So let's take a step back and talk about thyroid nodules. I would be remiss if I did not show this slide, which is probably one of the more famous slides. You're all familiar with it. You've seen this data. But Dr. Mazzaferri was a dear friend and a mentor to me. But this data is very important because it shows us that thyroid nodules are, of course, very common. We're not very good at palpating them, but as we get older, they're much more commonly seen. But the risk of malignancy in these nodules is around 7 to 14% overall, and this is really largely for adults. We talk about this risk of malignancy. So we have a 13-year-old. We need to know what's the risk of malignancy in a 13-year-old with a thyroid mass. And if we assume this was a thyroid nodule, which it's technically not, what's the risk of malignancy in that thyroid nodule? So there's very little data to tell us this, but this more recent study showed a group of patients under the age of 20. There were 300 patients in this study, and this was done in Boston. And they were able to identify a significant number of patients who did not need any further intervention just by the ultrasound appearance of the nodules. whether they were sub-centimeter or whether they were cystic. They identified that a good portion of them didn't need any further intervention. They identified 17 toxic nodules, so those were not concerning for malignancy, but 125 of the 300 nodules underwent FNA, and they found that 22% were malignant. And you can see that females were far more likely to have nodules than the males, and they were more likely to have thyroid cancer in this study. This is really the best data we have on pediatric thyroid nodules, so I think it's important for us to be aware of this rate of malignancy that they saw. Now, it's also important to remember this is one center's experience, Boston, it is a tertiary referral center, so therefore they're probably going to get the more suspicious looking nodules just by that virtue of that fact. Another study out of Boston looking at longitudinal risk of malignancy based on patient age. So we often argue about whether the risk of malignancy in a nodule is higher if you're older or lower if you're older. And this study very nicely put that to bed. And you can see that the risk of malignancy in a given nodule is lower as you age. So that the younger folks had a higher risk of malignancy, around 23%, and there was a 1.6% reduction in risk of malignancy for each decade. Now, the caveat here is that the patients who are older, when they did have cancer, tended to have more aggressive cancers. So it is an important balance to weigh and to really evaluate the nodule by ultrasound and say, is this nodule sonographically suspicious? Even though I have a 70-year-old who only has a risk of malignancy of around 14%, is it an ugly nodule by sonographic appearance, or is it a really reassuring looking nodule? So back to the guidelines for the pediatric nodule management. This is recommendation 4. They say that patients with evidence of autoimmune thyroiditis, so I would argue in our patient, mom has Hashimoto's, she has changes on ultrasound consistent with that, and a mild elevation, though normal, serum TSH. So it's important in those patients who we suspect might have autoimmune thyroiditis that an experienced sonographer evaluate this patient, and further evaluation with FNA of any suspicious findings be performed, particularly if there's any palpable adenopathy. But I would also add to that we need to be looking in the lateral cervical neck and even behind the thyroid in these young patients for the evaluation of suspicious adenopathy. That needs to happen at the initial ultrasound because, of course, that's going to change our pretest probability of cancer if we see suspicious lymph nodes. So in this patient, she has asymmetric microcalcifications throughout the right lobe, and though she does not have a discrete nodule, those microcalcifications are highly concerning, and that right lobe needs to be aspirated. When we take a step back and look at just patients with thyroid nodules, not necessarily our case, but looking at children with thyroid nodules should have the same evaluation and treatment as adults, with some very important exceptions. Ultrasound characteristics and clinical context should be used rather than size alone to identify nodules that warrant FNA. So if we use the size threshold of 1 centimeter for adults, a child's thyroid is of course significantly smaller than an adult's. So a 1 centimeter nodule does not mean the same thing in a child that it does in an adult. So if a nodule looks sonographically suspicious and it's 8 millimeters, then it probably warrants further evaluation because proportionally speaking, that nodule is probably similar to a 1 centimeter or even greater sized nodule in an adult. So just think about the proportions of the gland and take that into context. Another important distinction is that FNAs in children should be performed under ultrasound guidance every time, even in a case like my patient who has a palpable mass, maybe even a visible mass in the thyroid. That nodule or that mass should be aspirated under ultrasound guidance. Preoperative FNA of a hyperfunctioning nodule in a child is not indicated as long as the lesion is removed. So a toxic nodule in a child, if it's going to be surgically removed, we don't have to do FNA. If we're going to do RAI, then we should do an FNA. Another important exception is that a diffusely infiltrative form of papillary thyroid cancer can occur in children and should be considered in a patient with a clinically suspicious gland. So this is our patient. So though she doesn't have a mass, she's got a clinically suspicious looking lesion in her gland overall, and that is very concerning for this diffuse infiltrative form of papillary thyroid cancer. Surgery is favored over repeat FNA in most nodules with an indeterminate cytology. You all heard a very nice talk yesterday about molecular testing. In the adult population, we're routinely using that for indeterminate nodules that have a benign or reassuring ultrasound appearance. Molecular testing is appropriate to rule out malignancy, but in children, those molecular tests are not studied. Therefore, it's recommended that they have surgery to remove that indeterminate nodule. So our patient undergoes an FNA under ultrasound guidance, and the cytology is suspicious for malignancy. So the next question is, what is the extent of surgery that we should recommend? Her right lobe is the only one affected. The left lobe looks sonographically normal. So the guidelines recommend that for the majority of children, total thyroidectomy is recommended. Now, in adults, we are moving away from total thyroidectomy, as you all are aware, and we're doing more and more hemithyroidectomies because the risk of recurrence is lower. But in children, we know that the risk of recurrence is very high if we only do hemithyroidectomy. And hopefully these children have a very long life ahead of them, so they have a very long time for which they could develop a recurrence. So this is kind of a different mentality than what we do with adults now. So in long-term analysis, bilateral lobar resection compared with lobectomy has been shown to decrease the risk for persistent and or recurrent disease. And that's an A-level recommendation, so the strongest level recommendations. We don't get a ton of A-level recommendations in pediatric guidelines, and we certainly don't get very many in the adult guidelines either. So it's largely based on many studies. This is one of the better studies, I thought, from the Mayo Clinic's experience. They have long-term follow-up of their patients treated between 1940 and 1969, and when they followed them up long-term, you can see that those patients who had lobectomy in the black dots were much more likely to have recurrent disease than those folks who had total thyroidectomy. And in this study, they did 86% of patients had a neck dissection with removal of lymph nodes, 78% had lymph node metastases. So these children are already at a high risk for recurrence. We need to remove all the thyroid tissue so that we lower that risk of recurrence. What is the frequency of lymph node metastases in children, and what is the frequency of pulmonary metastases? In this previous study, I just showed you the risk of distant metastases in initial presentation was 6%. The numbers vary depending on the study. So you can see these are various studies that I listed, and by no means is this all inclusive, but you can see that the risk of lymph node metastases in children is significantly higher than what we see in adults, so as high as 74% in one study. And it is largely going to depend on how rigorous of a pathologic examination you have, if the pathologists are finely slicing each lymph node that's removed, whether they catch that microscopic metastasis within the lymph node. So that probably accounts for some of that variability, but the take-home message there is children are likely to have lymph node metastases, so we really need to look for them. Distant metastases, fortunately, are less common, but they're still more common than what we see in adults, depending on the type of cancer in adults. But typically with papillary cancers, we say 5–6% risk of distant metastases at presentation. And you can see that in all of these studies, it's higher in children. So, should we do a central neck dissection in our patient? Knowing that central neck nodes are not very easily visualized on ultrasound, and knowing that 45% of the time at least our patient is going to have lymph node metastases at presentation, should we do a central neck dissection? Now, arguing against that is these are young people, high risk of complications because their parathyroid glands are very small and difficult to identify. So there's a big risk. There's a definite reward, but there's a big risk associated with a central neck dissection. So the guidelines say that patients with papillary cancer and no clinical evidence of gross extrathyroidal extension. So this is something that is sometimes assessed on ultrasound, and it can be difficult to assess preoperatively. But if you see evidence that suggests the tumor may be spreading outside the thyroid capsule, then a lymph node dissection is appropriate. But in the absence of that, prophylactic central neck dissection can be selectively chosen. If the patient has local regional metastases, it may be beneficial to consider central neck dissection. But the experience of the surgeon also needs to come into play in this. So these are typically best done, central neck dissections are best done by an experienced surgeon who does operate on children with frequency. So these are usually going to be regional referral centers. So patients with unifocal disease, an ipsilateral central neck dissection can be done, and the contralateral neck dissection can be performed based on the intraoperative findings. And this may help sort of balance the risk associated with this central neck dissection. Now, if we look at our case, it's actually a little bit easier sometimes in children to identify central neck nodes. And in our patient, she did have several nodes that looked highly suspicious. If anyone in the audience is doing ultrasonography on their own, you recognize that often with Hashimoto's thyroiditis, there are associated lymph nodes that appear abnormal in behind the thyroid, inferior to the thyroid, and even superior to the thyroid, and in the lateral neck. But they typically appear to be reactive. They're enlarged, but they have the normal architecture of a lymph node. In this patient, I'm showing you two areas that are highly suspicious. So this hypoechoic mass is actually located inferior to the inferior pole of the thyroid, and that is a suspicious lymph node. And then if we look at the thyroid in the sagittal view, this is the inferior pole of the thyroid here. You can see this mass here, and there's actually, you can see the beginning of another one right here. So those are suspicious nodes. So this is a patient in whom I would recommend a central neck dissection. When we look at her lateral neck on ultrasound, she also had some suspicious looking nodes, and this is a chain of 3 nodes in her lateral neck, extending from level 4 up into level 3. So all these nodes need to be removed. This is just another picture of some of her lymph nodes, and you can see the jugular vein here in the carotid artery. This lymph node is compressing her jugular vein, and it has chaotic internal blood flow, suggesting that it is a suspicious lymph node. So in this case, we aspirated a lymph node, proved that there was malignancy in there with cytology and thyroglobulin washout, and then decided what the extent of her surgery needed to be. So in children with thyroid cancer, a central neck dissection is recommended for those who have malignant cytology and clinical evidence of gross extrathyroidal extension or local regional lymph node metastases. And even if intraoperatively the surgeon identifies abnormal nodes, you can, of course, then change the procedure to include a central neck dissection. And this approach may reduce the likelihood of needing additional surgery down the road and hopefully improves disease-free survival. And as far as lateral neck dissections, berry picking is no longer recommended. So compartment-oriented clean-out or resection of various compartments that are involved with disease is the recommended approach. Attempting to use palpation is not effective, and it certainly increases the likelihood of recurrent disease. When you have a lymph node that appears cytologically suspicious, or sonographically suspicious, so that lymph node that I saw inferior to the thyroid, if she didn't have those ugly lymph nodes laterally, I would have aspirated that lymph node inferior to the thyroid, but she had lateral nodes too, so that made me think that central node is probably a malignancy. But we should perform cytologic evaluation of that lymph node with FNA, and then measurement of thyroglobulin in the washout. So back to our patient. She has a total thyroidectomy, a central neck dissection, and a lateral neck dissection on the right. Her surgical pathology shows diffuse sclerosing variant of papillary thyroid cancer in the background of Hashimoto's thyroiditis. So her tumor measures 4.1 centimeters, basically the whole right lobe. There's no extrathyroidal extension. Vascular invasion is seen in greater than 4 vessels. So as you just learned from Dr. Lee's talk, that is very concerning for a higher risk type of tumor. She has a significant number of involved nodes, 12 out of 46. Her largest nodal metastasis measures 1.6 centimeters. No extranodal extension was noted. So by staging with TNM, she's a T3N1B. So let's talk about TNM staging in children. So TNM staging, as we know, is supposed to help us with determining survival and giving us an idea of whether this tumor will kill a patient. And as we know in adults, TNM staging with thyroid cancer is not terribly helpful. But in children, it can be predictive. So this is just meant to show you what the likelihood of recurrent disease in patients depending on their TNM staging. So the presence of palpable nodal disease at initial presentation can help with the treatment. So our patient, if she had nodal disease that was palpable and she has grossly involved nodes, which she did have on ultrasound. So the likelihood of her having multifocal disease is much higher, so 89% versus 16%. The likelihood of her having pulmonary metastases if she has gross nodal involvement is significantly higher, so 20% versus 0. So those patients who have no palpable nodal disease have a very low risk. No gross involvement of nodes have a very low risk of pulmonary metastases. Persistent disease is significantly higher, and recurrent disease is significantly higher in those who have gross nodal involvement. The ATA also created a risk stratification system for children. We're not so much worried about children with deaths, thankfully, with thyroid cancer, but we are worried about their recurrence risk. It's certainly very high in children historically. So a risk stratification to give us a better assessment of their risk of recurrence is similar to adults, but it's different in these important ways. So the disease grossly confined to the thyroid with N0 or NX disease in patients who have an incidental N1A metastasis. These patients are considered to be low risk. They have the lowest risk for distant metastases, and they may still, though, be at risk for residual cervical disease, especially those that are NX or N1A. Intermediate risk patients are those who have extensive central nodal involvement with minimal N1B disease. Those folks have still a low risk of distant metastases, but they have an increased risk for incomplete nodal resection and persistent cervical disease. The role of minimal extrathyroidal extension is unclear in children. This really hasn't been very well studied in children like it has in adults. And then the high-risk group, our patient would fall into this category. So she has regionally extensive disease with extensive N1B involvement. She has locally invasive tumors, or T4 tumors, and these folks are at the highest risk for incomplete resection and persistent disease, and they're also at the highest risk for distant metastases. So our patient is certainly at risk for pulmonary metastases, and when I'm evaluating these patients, I will try to prepare them for that possibility before I administer radioiodine, and this is, of course, what's driving my decision about radioiodine. So if we look at this patient, we're trying to decide, is this someone who needs radioiodine? I think we would all agree that our patient would benefit from radioiodine given the aggressive appearance of her tumor. So at the initial diagnostic whole body scan, TSH stimulated TG, if there's no or minimal uptake in the thyroid bed, then we can use the stimulated TG to determine whether or not we need to give radioactive iodine. So a low TG, we may not give radioiodine. If it's intermediate, we give RAI therapy plus or minus T4 suppression. And then if the TG is high with stimulation, then we would want to give I-131 therapy for sure with TSH suppression. So the diagnostic whole body scan, if we look at that, if the patient has distant metastases, we want to give I-131 therapy. If there's only cervical uptake in the thyroid bed, then we need to assess whether or not the patient needs surgery versus radioiodine. So this is where the ultrasound really comes back into play, and I'll often do a post-op ultrasound in these patients to assess whether any gross disease was left behind. It's a very difficult conversation to have with the family to say, I'm sorry, we need to go back to surgery, but that is the best treatment. So our patient, she has a diagnostic whole body scan, and it shows uptake in the thyroid bed and diffuse bilateral lung uptake. Her TSH is adequately elevated, and her TG is very high. So this is her post-treatment scan. You can see diffuse pulmonary uptake. There's a star artifact in her neck. And if we look at her CT scan of the chest, you can see she has some micrometastases within the lungs, and then there's this area of just kind of small metastases throughout one part of her lobe. So our patient we consider to have high-risk disease. We would recommend suppressing her serum TSH to below 0.1, and then the long-term surveillance for our patient is doing an ultrasound every 6 months, and then every 6 to 12 months, or less frequently thereafter. Want to measure the thyroglobulin on therapy for 3 years, then annually, and within 1 to 2 years, do a stimulated TG and a diagnostic whole body scan. So in patients who have known distant metastases, after a therapeutic dose of radioiodine, what is the best course of action? So I apologize for this busy diagram, but I do think it's important to kind of look at it. She needs to have a baseline CT scan of the chest if it hasn't already been done. And then we need to monitor the T4 and TG levels. Now, because she's young, we don't want to just scan her so often and give her all that radiation exposure, so we need to be judicious in the use of the scanning. So if the TG is rising and it's greater than 12 months after initial therapy, then we may want to do an I-123 diagnostic scan and determine whether or not it's time to give another dose of radioiodine. If the TG is detectable and stable, but maybe declining, then we can continue to observe and do T4 suppression and follow imaging periodically. So it just depends on where the patient responds to therapy as to how we're going to proceed. Now in our case, we got a repeat scan. This is the pre-treatment scan. You can see this little tiny metastasis here, and then there's some just diffuse heterogeneity that may be a little hard to appreciate on the images, but you can see that it is improved on this follow-up scan, and this nodule has gotten smaller. And in our experience with children, we have found cases where the pulmonary metastases completely resolve on CT. So it is a nice idea to get another scan following the patient at some point down the road. But when we look at her thyroglobulins, you can see that there has been a nice decline in her levels, but she still remains persistently detectable. So it's important also to follow these kids because she had a bunch of lymph nodes. We also need to do ultrasound. So in our patient, she has 2 suspicious-looking lateral lymph nodes that were missed with surgery. They're heterogeneous, making me think they're pretty suspicious. You can see the areas of hyperechogenicity within the lymph node here, and then it's just some hyperechogenicity here, but they're small. So they're 8 millimeters, and she has pulmonary metastases. So in this patient, I'm not necessarily eager to remove those. In the absence of pulmonary metastases, I may be more inclined to go after those lymph nodes, but it's pretty early in her therapy, so at this point, we're gonna kind of watch her. But if she didn't have any lymph node or any lung involvement, this is how we would proceed with the neck ultrasound. So if the neck ultrasound is positive, then an FNA and surgical consultation, plus or minus a CT scan of the neck. If the lesions are not amenable to surgery, we can continue to observe. But if the lesions look like they can be removed safely, then, and then they're enlarging or they're of a decent size, a centimeter or more, then those can be removed. Now, in patients with known distant metastases, the baseline CT of the chest should be done, and I think we already saw that. I apologize. So in our patient, she has elevated thyroglobulins. I just presented her case at Tumor Board a couple of weeks ago. So we've been following her thyroglobulin every 6 months, and we were performing an ultrasound of the neck periodically to follow those lymph nodes. They're not changing. Her TSH is adequately suppressed, and we're doing the CT scans directed by the thyroglobulin. So if the thyroglobulin starts to creep up, then I'm going to order another CT scan of the chest and determine whether it's the lymph nodes I need to go after or do another treatment with radioactive iodine. Now, some people would argue, why wouldn't you just do another treatment with radioiodine? And the concern is in children with pulmonary metastases, particularly those that do avidly concentrate radioiodine, these children are at higher risk of pulmonary fibrosis. So it is a delicate balance of giving enough radioiodine to treat the lesions versus giving too much that will kill her normal lung parenchyma. And in this child, I used dosimetry to guide how much radioiodine I was going to give her because I didn't want to give too much that if these lung lesions avidly took up the radioiodine, that it would kill her surrounding lung parenchyma. And it is a good idea to follow pulmonary function tests in these children at baseline and after radioiodine therapy to make sure that they're not developing a restrictive lung disease. So in this patient, I'm going to continue to follow her thyroglobulins, periodically order CT scans of the chest, and continue to follow these lymph nodes in her neck. And if they're enlarging, I'll remove them. If they're staying stable, they're not harming her, they're in the lateral neck, they're small, and we can just watch them. They may be partially treated with radioiodine, or if her immune system keeps them in check, I'm perfectly content to leave them alone for now. So with that, I will stop because I'm over time. Obrigado.